Welcome everyone. Welcome everyone on board. The topic which we will be discussing today is have anybody has an idea what is this abdominal compartment syndrome? Dr. Haifa, what is abdominal compartment syndrome?
Okay. Hello, assalamu alaikum. How are you, Dr.
Walaikum
Zishan?
assalam. Yes, Alhamdulillah. Dr. Haifa, what is do you know some words about abdominal compartment syndrome?
Yeah, I will tell, but not exactly. It is
No problem.
when the intra-abdominal pressure increased more
Yes.
than 12
Yes.
because of intestinal edema after surgery, laparotomy.
Very good.
Maybe like this. I'm right.
You are absolutely right. Actually, fortunately, in this Zoom meeting, we cannot come through the mobile to hit anyone. Sir? So whatever you are saying, everyone, even whatever I will
Yeah.
say, everyone has to accept. But you are absolutely right. Okay. For any
Yes.
good reason, if there is increase in abdominal pressure, okay. So this abdominal
Yes.
pressure will be increased because either of contents or there is some extravasation of fluids.
Yes.
Yes. Or the wall. There is some problem in the wall. Okay. So any other
Yes.
now question is that for we will go in a little bit detail. Just for instance, think what other condition in anesthesia and ICU will behave like abdominal compartment syndrome. They will not
Laparoscopy.
laparoscopy. Very good.
Surgery.
What else?
Abdominal, not intestinal obstruction. I mean, vascular problem lead to gangrenous bowel and edema.
Yes.
Like vascular.
Yes, because injury, like end result of abdominal compartment syndrome is development of new organ failure. Am I right? Whenever there is
Yes.
because during coughing, during sneezing, during defecation, during micturition, the abdominal compartment increase. Okay, or transiently you are holding the urine, abdominal compartment will be increasing, but you will not say that it is abdominal compartment syndrome. Okay, so abdominal compartment syndrome, you will say that when because of this increase in pressure there is development of new organ failure. Okay, so this is the basic concept of abdominal compartment syndrome. Okay, so we will just have a look on uh, some of the data. Just a second, please. Okay, so actually, yes.
Abdominal pressure above 12 millimeter of mercury is called intra-abdominal hypertension. And when it exceeds 20 and it has some degree of organ dysfunction, then we call it abdominal compartment syndrome.
No, Zishan, I will. Yes, you are right, but I will just add on development of new organ failure. Okay, if for example the patient already has renal failure, okay, and it is not because of that obstruction which is occurring, we will not say it abdominal compartment syndrome. If we just have a look on when a fixed compartment defined by just a second, if I'm not wrong, can you mute please whosoever whose mic is on? Okay, so actually that will be called as hypertension, abdominal hypertension. Okay, I was just trying to find out there is exact definition which I remember. Yes, you see, this is what I was talking about. I'm sorry. Yes, this is sustained intra-abdominal pressure more than 12 millimeter of mercury, and abdominal compartment syndrome occur at pressure of more than 20 in association with a new organ dysfunction. Okay. If pressure raises, it will be called as hypertension, new organ dysfunction. Okay. So this is an important point which you should, whenever you are explaining or whenever they are telling you in MCQ, they will be because this is development of new organ failure because of increase in abdominal pressure. Okay. So these are the normal ranges 1 to 12 and grade 2, 12 to 15, 16 to 20, more than 20 and more than 25. Okay. So these are the things. So now whenever there will be what will be the effect? What will be the effect of this hypertension? Okay. Systemic effects will be like when there is the vascular system is passing through the abdomen. Okay. So whenever there is increased pressure, there will be compression. So it will mimic just like autocoeval compression. So there will be reduced venous return. Okay. And there will be decreased cardiac output. And it will also reflect in the increase in afterload. There will be increase in afterload. Okay. So, and when the abdomen is full, and there is increased pressure, just like laparoscopic surgery, almost the same thing you can quote. So there is a decrease in FRC, decrease in PO2, patient will develop hypoxia. Okay. And there will be like other thing which will be that the patient will not be able to breathe properly. There will be shortness of breath if patient is awake, for example. In that condition, this condition occurs when we have a patient with ascites. Okay. So by the way, I will just use this. Just a second, please. This is FRC. This is FRC.
How are you?
Just a second, please. If you can mute the mic, please. Whose mic is open, please mute the mic. Okay. So effect on pulmonary system, we told renal system, there will be decreased GFR, oliguria, decreased urine output. Okay. And there will be increase in ICP or IOP. Okay. And there will be ischemia, because this is one of the main we are focusing on the pressures, the intraocular pressure, intracranial pressure, and cardiorespiratory system. Okay. So these are the more important things. So what will be the causes? Okay. For causes, you see there is someone who is just putting some lines on the screen. I don't know how to stop it. Okay. Anyway, so either as I told you before, either there will be decrease in compliance, abdominal wall compliance. Okay. Or there is contents in the form of gut, if they are increased, or intraluminal. Okay. Intraluminal or intra-abdominal contents are more. You know, who is putting these lines? This is very irritating. From whom these lines are putting? Anyways, I will try to cope it up. So either there is decreased in abdominal wall compliance, which occurs in actually obesity. And this is very important factor, burn. When there is burn in the abdomen, there is decreased compliance. So this will be a very important factor. Okay. And similarly, when they are after abdominal surgery, they are trying to close it, and there is it is again not able to. They are not able. There is no area to close it. The example for it is in liver transplant, especially in pediatric patient. Okay. When they are closing it, because the liver is big, So they are not able to, so they close it in stages. Similarly, in congenital diaphragmatic hernia surgery repair, post-operatively, they don't close it and they keep it to avoid this abdominal compartment syndrome. You can give a number of examples for that thing. Okay. And if they are doing prone positioning without abdomen being free, this will also lead to later on if it can lead to development of syndrome if it is prolonged. Okay. So some of the causes, like whenever there is luminal contents are more because of any reason, gastroparesis is occurring, ileus occur. Okay. So this may be one of the cause. Just a second. And other causes are like as occur in liver failure, ascites develop. So they are pushing the gut, and there is development of this one organ failure or development of organ failure. Okay, so these are miscellaneous causes: acidosis, hypotension, hypothermia. So mainly you just have to understand what are the main effects. Okay. So as we discussed about cardiovascular system, respiratory system. Okay. Now there is an important point on which the questions they ask is how to measure. Okay. So what are different ways of measuring? Zishan, would you like to tell? Or anyone who wants to tell? How to monitor or measure abdominal pressure?
Sir, we can measure either by urinary bladder, and second by intraperitoneal catheter or needle.
Okay, which will be more reliable? Like which will be direct and which will be indirect?
So direct would be intraperitoneal needle or catheter. It will be direct.
Yes. And indirect through, they can be measured through stomach? It is.
Stomach,
Okay.
sir, no idea.
Intragastric they can measure. Intravesical is usually used, and but it can be measured. The similar principle is the same. There is a bag of upstairs. You are putting a cannula. You are putting a transducer and measuring in the bag in the upper abdomen, and the same bag you are putting from the urethra. You are measuring it. So actually, concept is the same. Okay. So this is all indirect methods. And the direct, as you told. Okay. We measure also during laparoscopic surgery abdominal pressure, the pressure reading which is coming, it is also like direct. They are measuring through the port. Okay. Okay, this is another important. So how to just a second, because this is there is one abdominal perfusion pressure. Yeah, I was just reading somewhere. Is there any concept of abdominal perfusion pressure? I cannot recall it. Anyways, it is something else. This is a filtration gradient by which the kidneys are working actually. Okay. So it is mean arterial pressure minus interabdominal pressure.
Sir,
minus...
it is a map. Yes, sir. Yes, sir. Map minus intra-abdominal pressure. Basically, it increases. It basically, if the pressure is increases, it decreases the perfusion of the abdominal viscera.
Because they will compress it. Okay. And there will be increase in proximal tubular pressure. Okay. So the gradient by which the filtration is occurring will decrease. Okay. So how to treat it? What will be the management? Because the management usually in the form of like usually sign and symptoms we have talked. Sign and symptoms are respiratory, cardiovascular, abdominal. Because of increased pressure, there is decreased urine output. There is a problem in oxygenation. blood pressure can fall, ICP will raise, IOP will raise. Okay, so how to manage? What will be usually the answer will be treat the cause. Okay, so you will be trying to, some causes will be correctable and some causes will not be correctable. Okay, like if like any compartment, if you the similar finding occur in the like crush injuries, or even after post
So tumor,
surgical.
sir. Yes, a
I'm
tumor.
sorry.
So tumor, intra-abdominal tumor. I think
Yes, yes.
difficult to treat the cause.
Difficult to treat. That's why they only make a stoma. Okay, so that's why whenever there is untreatable tumor, they only create a stoma to relieve the abdominal pressure. Okay, so the basic purpose is to relieve the obstruction. So this is one of them. And I was actually telling that the similar finding occurs in the limb compartment syndrome. Okay, because actually the theory is the same. There is a compartment created in the anywhere. This compartment, even if you just think logically, the same principle occurs in the brain. There is a compartment. One thing is compensating the other. That is what is Monroe Cali doctrine. Okay, that there is CSF, there is blood, and there is brain tissue. So either of them, if increase, it has to be compensated by the other thing. If it does not occur, there is increase in pressure. So same theory is here, that actually, because here there is more area, so this occurs like effect is relatively slower, but it will be as detrimental as in the brain. Of course, the nervous tissue will be damaged more. So the basic principle will be either to open the compartment, as they occur in the burr hole, as they occur in the lung compartment. They do what they do, what they know, what they make it. I forgot the name. If anyone can use the word, Usman, what they do.
Sorry, sir. What's the question?
My question, to relieve the pressure in this limb compartment, they make the incisions. What, there is a specific name for it. What is that?
Fasciotomy.
Fasciotomy. I'm sorry, I was not able to recall the name. Okay, so it will be fasciotomy. So this will be similarly here. They can open the abdomen. Okay, so if they want to decrease the abdominal contents or intraluminal contents, they have to avoid the remove the obstruction, or give some enema, or give if there is ascites is the reason, so ascitic tap will be required. Okay, so actually it is a simple topic, but because it is being asked number of times. Okay, and any question about it? This will be either surgical decompression. So actually they have written a number of things in headings, but the main theory is the same. Okay, so if remember one thing, whenever you are doing any laparotomy, actually you are doing this scenario daily in any patient. When you open the abdomen, you expect and you should anticipate sudden hypotension. Okay, so in this patient, you have to load the patient with fluid. If the patient cannot receive too much fluid, then you should be using vasopressors. Okay, because if you don't do it, you will be in trouble. Okay, so you have to anticipate, and you have to give because the further management will be because of according to the cause. Okay, but remember these basic thing, that either you have to give fluid or either you have to give vasopressors at that time when they are decompressing it. If you cannot give too much fluid, then you have to use vasopressors, because otherwise patient will collapse. Okay, and you have to anticipate. Similar sort of thing occurs whenever they are removing any organ or any tumor. Okay, so when they clamp it, remember one thing, that at that time there can be sudden hypotension. Okay, so this is actually the principle is the same thing occur when there is opening of tourniquet. Okay, when they reposition from lithotomy, you should be expecting the same thing. Okay, if they are doing a foot side down, similar thing you should expect. Any change in positioning, you have to anticipate in the similar way as you should anticipate for abdominal decompression. Okay, so organs, you can measure. Actually, CVP will be also be helping thing. Pulmonary artery catheter may be misleading, but you can follow the trends. Okay, and cardiac output optimization through either fluid or vasopressors. Okay, so anything which need to be clarified more? Okay, so thanks a lot for your presence. Actually, I was a bit busy, so I just wanted to have a small topic. We are trying to start cardiovascular system. Most probably, we will start on Saturday. And before that, I will try to have some small topics similar tomorrow, inshallah, 10 p.m. Pakistan time and 8 p.m. Saudi Arabia time, inshallah. Okay. Thank you.
Thank you, Dr. Sushan. Allah. Thank you very much.